So, good afternoon, colleagues. Thanks for joining us. Today's webinar will be focused on ECIC bypass surgery and is hosted by Mr. Holsgrove, who's a consultant neurosurgeon in Salford in Manchester. Before we start, just some housekeeping. If you've got any questions, just upload them up to the chat and we'll work through systematically at the end. Alternatively, you can raise your hand and take turns to ask the questions. If I could ask that everybody just try and keep the microphones on mute whilst we're talking as well. And at the end of the talk, I'll send a link out for some feedback, which we would be grateful if you could complete. So without any further ado, I will hand you over to Mr. Holsgrove.
Thank you, Sean. So as Sean says, we're going to talk about ECIC bypass surgery. So to start with, can anyone give me any indications for why you might perform this procedure?
Moyamoya disease.
Yeah. So that's a good one to start with. Any others? So why are you doing it for Moyamoya disease?
There is stenosis of the intracranial terminal ICA vessels.
Yeah. So they're ischemic, aren't they? So you could consider it for an ischemic cause. Any other indications, you think? Okay, well, we will come to them. Okay, so we'll start with the case then. So have a 55-year-old man presents with memory impairment and intermittent left arm weakness and not much past history other than ischemic heart disease. So any investigations you'd like to perform for him, he's somehow, with that presentation, has found his way to a neurosurgery clinic.
So an MRI brain.
Yeah, okay. So there you are. So what you see there? Sadly, you only get one slice. So what's your view on that?
There's white matter lesions, suggestive of ischemia.
Yeah, so it's difficult to say exactly based on one slice of one sequence, but yeah, so if I tell you that these signal changes here, so these high signal areas are due to ischemia, how could you describe that area of the brain? How would it classically be described in terms of ischemia?
So it's multi-territory in terms of the
where's it falling in terms of
watershed?
Yeah, so watershed. And anything else you might notice about the appearance of the cerebral hemispheres?
Quite atrophied.
Yeah, symmetrically?
Seems to be more on the right side.
Yeah, and that would fit with his presenting symptoms as well. He had more left-sided symptoms than right, although he does obviously have evidence of ischemia bilaterally. So what would you want to do for workup for him? You've identified he's got symptoms, he's got quite widespread ischemia, watershed in parts.
You need some vascular imaging.
Yeah. So what choices have you got for that?
CTA, MRA as non-invasive methods.
Yeah. So he's had them, but then he's found himself having an angiogram now. But you're right, you would start with those, and they showed abnormal appearance with carotids. And then we'll choose someone else. Dan, are you there as well? Can you describe these images to me? Dan Lewis. No. Lost him. Ahmed?
So I think this is right ICA DSA on the it's a lateral view on the right and an AP view on the left. So I mean, it looks like there isn't really much penetration of the contrast very far on the MCA.
Yeah. So
territory.
if we start on this one, so this is an AP view, as you say. So ignore that. That's incorrect. So we're looking as we would for any imaging investigation. Normally, they're facing us, so it's a right-sided carotid injection. Okay. And so if we go up, so you've got carotid here. What part of the carotid is this?
I mean, is this the carotid siphon into cavernous part?
Yeah. So we're looking at and that's so. Although you might think it's abnormal here, we're just looking at the its trajectory through the cavernosus sinus. Okay. And then so what would you normally expect to see here? How would the carotid terminate normally?
It would bifurcate here into MCA and ACA.
Yeah, and we're not really seeing that, are we? It's just a bit of a jumbled mess essentially. But we can say it. But in terms of describing it, you're right. It's an AP view of a right-sided carotid injection is how you describe it, and then the lateral can give us some more clues. So as we come up, what branches might you expect to see?
That's the ophthalmic.
Yeah, that's right. And then what would this be?
It would be the PCOM.
Yeah, and just distal to it.
The anterior choroidal.
Yeah. So we can see there's a fairly big PCOM there, isn't there? But again, we're not really seeing the MCA branches as we'd normally expect to here, are we?
Mm-hmm. No.
And then this is the left side, and it's very similar findings, really. Okay. Anything else you'd like to see? Radiologist wondering what other views injections you'd like.
So to complete the full set, you also need the vertebral arteries and the external carotids injections in the. Yeah.
So this is what's this? We're looking at this one here.
So that's the left vertebral artery.
Yeah. Okay. And so again, we've got AP and lateral here. And is there anything you notice on this?
So I mean, I must admit I'm not too familiar with DSAs, but as a just ST1 just starting, but it's the vessels seem very narrow in caliber and very sort of diffuse.
Yeah, so they don't look. This area particularly stands out, doesn't look normal, and there's big collateral forming there. For a posterior circulation injection, it's all passing forward quite a lot, so it's following collaterals along the corpus callosum here to feed the posterior circulation is contributing to the middle cerebral artery supply, isn't it?
Yeah.
So he's making do, but again, it would fit with his brain is trying its hardest to get what perfusion it can, but it's not enough based on those imparts and his progressive symptoms that he has. So what do we think for the diagnosis for this man?
Moya.
Yeah. So and what in terms of moya, what moyas do you know of? How could you another word that you could put on the end of it? There's moya disease and moya syndrome. They would normally be described as, depending on sort of whether they classically fit the description of disease, which we'll come back to later. So how do you decide he has some form of moya or sort of occlusive arteriopathy? How do you want to manage him?
Presumably a bypass procedure in
Yeah. Clues in the title of the talk.
Yeah.
So that's an option or some form of revascularization surgery. So what options for surgery for moya do any of you know
of? Well, you can have a direct bypass or an indirect bypass.
Yeah, that's right. Yeah, and what's indirect options are you aware of?
So indirect options would then include getting a branch of the superior temporal together with the fascia around it and just placing it on the dura.
Yeah.
Or opening the dura and placing it directly on the cortex without making any particular anastomosis.
Yeah, that's right. So because if you're choosing your patient correctly and their brain is ischemic, then generally whatever you do should enable it to develop some collateral blood vessels and treat it. And that's why there is such a wide range of treatment options. So that would include multiple burr holes. So some of these aren't used as much nowadays, but over in the past, people have used multiple burr holes, EDAS, which is where you suture an STA vessel to the cortical surface, and you would normally, so you can do some of these in combination, so you can invert the dura as well, so do a stellate durotomy and invert it. You can put muscle there, but again, that doesn't tend to be used now, so people used to lay on temporalis, but that's quite epileptogenic, so most people wouldn't do that now. Again, in the past, people would put omentum onto the cortex. Again, that's not used very much now, and direct arterial bypass. Before you embark on your surgery, what would you need to know? What's this telling us? What injection is this that we're looking at? I'll tell you, it's a lateral view.
I mean, it's the external carotid artery.
Yeah, that's right. Yeah. So it's the external carotid, and what's this here? We've mentioned it already. We might like to use it.
Superficial temporal artery.
Yeah, it's a superficial temporal. Here we're seeing the middle meningeal, and often, so it's an injection. When you're giving the actual injection, you're injecting contrast under pressure. So sometimes you get some reflux down the carotid and up the internal. So here we're just seeing a shadow of the internal carotid here. And so normally, if you were utilizing the superficial temporal, you would use this branch, which is the parietal branch, because quite often it's nice and straight, and therefore you can have a linear incision along it, whereas this sort of often tends down to the frontal branch courses down towards the forehead. So you can use either or both sometimes. It depends on the pattern and the size. So this is not what he had, but this is an example of what multiple burr holes would involve. So often more commonly used to be used in children, and it would often be a bicoronal incision, and then lots of burr holes, opening the dura, opening the arachnoid, and then that would permit collaterals to develop from the scalp effectively. You are limited if you've done it once, then you would risk, if you ever did a repeat operation, you'd risk disturbing collateral circulation that developed. This is the EDAS. So again, you can see the superficial temporal, and it's got its couple of fascia around it. So the dura's been opened, and you would normally open the arachnoid in multiple different places with the and then you stitch it down to the peel surface. And this is for a direct bypass, so you would find a suitable recipient artery. So you want one that's normally you'd want it of more than 1 millimeter diameter. So you can see this is sort of about 1.5 millimeters, and you want to try and find one that's free of lots of other vessels, because you don't want to induce sort of harm or ischemia. They're very vulnerable brains already, so you try and find a section without any branches coming from it. You can then sort of open the arachnoid along it, temporarily trap it with these temporary clips. And here we have the STA coming with its fascia around it. And you can see the fascia's being cleared from this section of it, and it's been cut at an angle and then fish-mouthed at one aspect of it. And by doing that, if you remember your equations of flow, you don't want a stenosis where you do your anastomosis. So by doing this, it lets you sort of maximize flow through the graft. And also, this can also, depending on can have a size mismatch between the STA and the recipient. So therefore, you can adjust your length of your arteriotomy or the degree to which you push them out to try and match the sizes together. Once you've done that, you stitch it on, and then you would normally check the flow. So we'd normally use ICG, and you can see that the flow comes in, and we could then measure it. And you can see from this is the time since you click the button on the microscope, and it uses infrared excitation of insulin in green, which is given intravenously, and then you can see that the flow is coming into the STA before the normal cortical vessels, which is suggests that it's sort of, well, this is a healthier vessel. Now for this man, he had a combination of procedures. So if you remember, we talked about EDAS, direct bypass. So his frontal branch of the STA was larger. So we used the frontal branch, which is this one, for the bypass, and then used the parietal branch for an indirect approach with EDAS, and you can see it's coming in here, and then it emerges and carries on afterwards, and it's stitched to a variety of places. So you can use combination approaches, or sometimes people would use double barrel bypass where they use both branches to for two anastomoses, and you might do that either side of the Sylvian fissure to provide additional perfusion to the temporal and the frontal lobes as well. But it depends on the layout and the extent of the ischemia. So here's another case. So this is a 36-year-old woman, and she presents with sudden onset headache, vomiting, and facial weakness. So how do you like to investigate her?
CT scan?
Yep, so she has a CT scan, and that's it. So what do you see there?
ICH within the right internal capsule.
Yep, that's right. So she's 36, she's got an ICH, no history that you're aware of. She's Japanese, that's otherwise she's there's no normally fit and well, no medications. So what else do you want to do?
Might need CTA as well.
Yep, so you do a CTA, and that shows some abnormal vessels, but you can't quite see what.
Next step is a DSA.
Yeah, so she goes on to have a DSA. And what do you see here? So if you start on this side, this is the side she's had the hemorrhage from. What's this view?
Looks like lots of neovascularization coming off the right ICA, puff of smoke appearance.
Yeah, that's right. And a similar on the left. So this shows a in the left case. It's sort of puff of smoke, which I understand is the moya moya is the Japanese for the sound a puff of smoke makes. So that's what that is. So it's these tiny collateral vessels, and it's thought that they are, or certainly act in a more fragile way and histologically are abnormal, and so they can lead to hemorrhage. So moya moya, as well as causing ischemia, can present with hemorrhage. So she's had a hemorrhage. What do you want to do with her?
Let her recover from the hemorrhage.
Yeah. So she made a good recovery. Anything else?
We got further DSA images of the rest of the vessels and consider bypass.
Yeah, and what would you consider bypass for here? She's got no ischemic symptoms. She's made a full recovery from her hemorrhage.
I think it would be with the aim of reducing pressure in these fragile vessels coming from.
Yeah, so that's the theory, and there is some limited evidence from sort of cohort studies that bypass following hemorrhage can reduce the risk of repeat hemorrhage, and so that's what she had. So she had a bypass on the affected side. She's still thinking about whether to undergo it on the other side. And this is not her, but it's another woman that presented with hemorrhage. And again, so this is before and after. And so it's a common carotid injection. So you can see the internal carotid here, external branches here, and you can see following it the sort of this part is now being perfused by the bypass. And it's thought that then takes, as you said, takes the pressure off the moya vessels, which hopefully reduces their hemorrhage risk. So in terms of working up for this, there's a few things you can do. So one is, which we talked about, is if we think there's ischemia, so you can look at perfusion imaging, and there's a variety of different ways that you can do that, and we'll come back to that. And the other thing is looking at collaterals. What you don't want to do is cause harm by disrupting collaterals that are already there. And as I say, the brain is very good at developing collaterals. So here's an example of an external injection. We have the STA here, middle meningeal here, and both of them, so it's difficult on one screenshot, but both of them, if you let it run through, do then provide an intracranial circulation to section. So you can see it happening here. This does go on to provide sort of past the motor strip supply here. And so what you wouldn't want to do is disrupt them. So you could do a craniotomy, disrupt them in the meningeal. If you did a direct bypass, you could take the STA, but then you'd be disrupting this. So in this scenario, depending on how the patient is and how they presented, you might choose to do nothing, or you might choose a technique by which you won't disrupt the supply that's already there. And likewise, so I mentioned about sort of if the brain is hypoxic enough, it will often find collaterals from somewhere. This is a girl with faceless syndrome, and part of that includes an arteriopathy, and she does have some ischemic symptoms, and she's had a VP shunt. And what we can see is that she has this external branch here passing through her shunt burr hole, and giving, if you follow it through, it does sort of supply this whole section. So it's would be worth knowing before you revise that shunt. Okay, so if we look at another man, so this is a 47-year-old man, and he initially presented 2 years ago with a sudden episode of left arm and facial weakness. He smokes a lot, and he's had some progressive intermittent symptoms since that time. So how would you like to image him?
CT angio, and then a DSA.
Yeah, so you could do all those things, but so you'd probably go to stroke initially. What would the average stroke workup be for someone presenting with a sudden onset weakness?
That would be an MRI.
Yeah, so often you might get a CT in the first instance, and then an MRI scan, and then sort of work up following that, depending on do they find strokes and where are they looking for them in terms of echoes, Dopplers, vascular imaging. So what do you find? So he has his MRI scan.
I think there is some periventricular leukomalacia. Then there are also some old infarcts.
Yeah, so it's in fact very similar to the scan we looked at earlier, isn't it, for the other man? Yeah. He's got watershed infarcts predominantly affecting the right cerebral hemisphere, which looks somewhat atrophic compared to the left side. So what else would you like for him? So you've mentioned some of it, so we could do some vascular imaging. So he has a CTA, and what are we looking at here?
I think we can see carotid stenosis.
Yeah, so what's this vessel here?
The common carotid.
Yeah, so that's the common carotid. And here?
That is external carotid.
Yeah, and not here?
That is occipital.
No, so we've got common carotid. Whoops. We've got common carotid, external carotid. What should be here?
Pharyngeal
Internal carotid.
or internal carotid, sorry.
Yeah, so it's not there, it's missing. So you can see some calcification there. So he's got quite severe atherosclerosis, and he's got occlusion of his right internal carotid. So what would you like to do for him? He's got ischemic evidence of strokes. He's got some ongoing symptoms, and he's got an occluded carotid.
Probably need to evaluate the degree of stenosis in that internal carotid, either ultrasound or dedicated MRI position to look for it.
Yeah, it's gone. It's occluded.
Well, then maybe if it's occluded, then would you want to do endarterectomy?
When would you do endarterectomy for stroke? What levels of stenosis would they normally assess?
I think critical stenosis.
Which is
Up to 99%.
figures they look at, don't they? What's above what percentage would they normally consider?
Above 70%.
Yeah, so above 80%, they would normally consider endarterectomy. But what if it's completely occluded? Would you normally undergo an endarterectomy for an occluded carotid?
No, you do a bypass.
So you could do a bypass. Is there any evidence out there to support you in that decision, do you think?
No.
It's the contrary. So looking at bypass, so it used to be used fairly commonly in the 70s for ischemia, but then the ECIC bypass trial in 1985 had lots of patients in it and looked at patients who'd had recent stroke with ICA or MCA stenosis or occlusion secondary to atherosclerosis. And it's looking at best medical care versus best medical care and bypass. And the bypasses worked well, so they had the 90%, 96% patency rate or follow-up, but no benefit demonstrated with bypass over best medical care alone. However, there were lots of criticisms about the inclusion criteria and the centres that were performing the bypass in terms of low volume centres and prolonged cross-clamp time for the ischemic time while they were doing the bypass. And so following on from that was the carotid occlusion study, which published in 2011, and that looked at symptomatic ICA occlusion with hypoperfusion demonstrated by PET imaging. And it was terminated early with, again, no benefit demonstrated. And again, that has been sort of further evaluated, and it's felt that on the whole, the carotid occlusion bypass surgery wouldn't be recommended. And the main thing that was unexpected in this trial was the rate of stroke in the medical group was much, much lower than predicted. So it seems that the medical therapies are perhaps better than anticipated. There are some circumstances where now bypass would be considered, and that tends to be in people. So the carotid occlusion study looked at people who had an episode that was symptomatic, and it's felt that there may be benefit for patients who are having progressive symptoms or ongoing symptoms. So the man in the case illustration there, about 3 or 4 times a week when he stands up, he gets facial weakness and left arm weakness, and he has to go and lie down to resolve the symptoms, which suggests he's having ongoing difficulties with hypoperfusion. He's not had any treatment yet through DNAs or his appointments. So if we look at ischemia, there thought to be 3 stages of impairment. And so if you look at reducing cerebral perfusion pressure here, the stage 1, you have a normal response in that your blood volume would go up, your oxygen extraction fraction would remain the same, and your vascular activity would go down, but it's all, but you're maintaining your blood flow. If you reduce further, then your activity sort of further reduces, your oxygen extraction fraction increases to maintain your metabolism, but your blood volume, your blood flow is starting to reduce, but you're not yet ischemic, and this is considered sort of misery perfusion. Whereas when you go here, so into stage 3, you've further reduced your perfusion pressure. You can't increase your extraction fraction anymore, and your blood flow is further reducing. Blood volume is going down, and you get end organ failure. So in this case, ischemia. And so this has been tried to use it to try and assist when to intervene with someone with ischemia. But as I say, those 2 trials have reduced by far massively the indications for bypass surgery, and now it would tend to be used for moya. And moya is recognised as a progressive condition. Therefore, if someone's presenting with ischemia because of the progressive nature of the disease, we normally consider intervening on that basis. There are lots of ways of assessing these, both directly, such as using PET, and also sort of as with surrogate markers as well, such as CT perfusion imaging, where you're comparing to a normal vessel, for example, the basilisk. So there are lots of different ways of assessing perfusion radiologically. That's a separate talk in itself, I think. So if we move away from ischemia and look at another case. So this is an 11-year-old boy, and he's presented with headaches and has an MR scan. So what you see here? Let's go. Anyone that's not spoken that would like to? There's plenty of abnormalities to choose from. Okay, so what's this?
So yeah, it looks, that could be like an arachnoid cyst.
Yeah. So if in doubt, you can always start off with just the basics. So particularly for an exam, so we're looking at a T2 axial site with an MRI scan, and then at least you've ticked some boxes. They know you can tell it's an MRI scan and what sequence you're looking at. So just start with basics. So we've got an axial T2, and you've identified that this hyperintense area would be consistent with CSF and what's this here?
Looks like a shunt.
Yeah, so he's got an arachnoid cyst, and many years ago he had a shunt inserted. Anything else that stands out?
So he has a low signal, well circumscribed area on the medial aspect of the left temporal lobe on the uncus.
Yeah.
It's like,
So what would create low signal like that?
air.
Yeah, so air could. So we can see air in the sphenoid sinus here. What else might create? What's this here?
This is a basilar, so it could also be blood.
So it could be blood. So if that's a flow void creating low signal, what structure are we looking at here?
I mean, it would be the left ICA or the cavernous.
Yeah, so it's the left ICA.
Mm-hmm.
So his headache gets better, and he goes away and isn't followed up for some reason for a few years, and then presents 5 years later. Again, he's got more headaches. What do you notice now?
Both may.
Oh, sorry, you've cut out there. Lost you. Anyone else?
Bigger.
Yeah, go ahead, Moise.
So the left ICA abnormality is bigger.
Yeah, it's bigger. So what was this that we were looking at before? Air here. What's this? What sinus is it?
Sphenoid.
Yeah, and then this is it's eroded into the sphenoid much more, and it's much bigger, as you say. So how would you like to investigate this? No one's really looked into this yet because they were a bit obsessed with the arachnosis.
We need dedicated vascular imaging.
Yeah.
Non-invasive again, CTA, MRA, probably MRA if he's 11.
Yeah, so he's well, we're on now. He's 16 now, but so he has an MRA, and then he goes on to have this. What do you see here? So what injection are we looking at?
So it's the left ICA.
Yes, they're both left ICA injections. This one is a bit earlier, and then this one's sort of a few seconds later. Okay.
Mm-hmm.
So again, so this is what we're looking at, isn't it? So he's got a rather large aneurysm there. Okay. What do you notice here? So it's a left ICA injection. Would you normally expect to see, what territory is this? What territory is this one?
Right, sort of. It looks like it would be from the ACA.
Yeah, but what would normally supply this area?
Or the right ACA or the right MCA.
Yeah, right. I mean, this is its equivalent over here, isn't it? So here we've got left carotid, A1 here, and the MCA here. And the equivalent over here is getting its supply via the ACOM and the ACA and collaterals here. Okay. That's something's amiss causing that. So what would that make you want to also look at?
So you need to look at the right ICA as well.
Yeah, right. Yeah. And before we do, where is this in terms of its anatomy? Is it intradural or somewhere else?
I think supraclinoid.
Do you think this is supraclinoid?
You need a lateral view to be more
Yeah.
assessed, no?
Yeah. So a lateral view would help, and you'd be looking at it in terms of its relationship to the ophthalmic normally. The other thing that can sometimes help is looking at the MR gives a slight clue that it looks cavernous, but then when we look at, so this is an oblique view, but even the supraclinoid ICA isn't normal. Okay, so we can see this is all dysplastic here as well.
Okay.
And then what view do we have here?
Right, vertebral, AP and lateral.
Right vertebral or
Left, yeah.
left vertebral? Yeah. Okay. And again, we can see there's a good peak on, and again, so similar to what we were seeing before, the MCA territory is receiving some supply, a decent amount of supply from that. And then if we look at the right, so it's not very easy it doesn't look like a carotid injection because it's not normal. So this is AP and lateral. What's this here?
ACA?
So it looks like it could be, but it's so
Is it heading posteriorly? Is that
this is going anteriorly.
Oh, sorry.
So it's the ophthalmic.
Okay.
And his carotid just peters out to nothing. Okay. And this is, if you imagine, he's not having that much flow through this. So when you do an internal carotid injection, you get lots of reflux of contrast back down and up the external, which is why we're seeing external vessels. Okay. So, oops. So we can see that he's got a very large ICA aneurysm, which is increasing in size over the years. He's only 16. His right carotid sort of is stenotic and occludes, and his right hemisphere is receiving cross flow via the left carotid, and his posterior circulation is also contributing to the left MCA territory. So there's which is probably because there's so much steel across to the left from, across to the right from the left carotid, but that's where the posterior circulation is contributing to this territory. So what are your options of what to do with him? Does it matter? He's got a big aneurysm of his cavernous carotid.
Presumably, that size is a very high risk of it rupturing, and you'll get a cavernous fistula.
Yeah. Any other danger if it ruptures?
Well, it'll rupture into the sphenoid.
Yeah, so it could have rather dramatic and life-ending epistaxis. Would be one potential, the way it's eroded through. But yeah, another risk could be a CCF, right, with a fistula. So, what if you decide you want to do something with him? What options have you got for him? How might you treat him? Again, you could always just make a guess based on the theme of the presentation.
So he needs a bypass on the right.
So you could have a bypass, but so what are you going to bypass? You could say his right side of carotid is sort of as occluded, and he's therefore effectively stealing lots of blood flow from the left side. So let's do a bypass on the right hand side. That would be a potential option. What that doesn't do, what's your aim from the treatment? Are you restoring flow to the right hemisphere, or are you doing something with the aneurysm?
So I think the aneurysm would surely need addressing on its own.
Okay, so how do you want to do that? What are your options for it?
Like a balloon occlusion with its anatomy and its size.
Yeah, so you could occlude it. However, the majority of his right and left hemispheres are receiving blood flow through that carotid. So that would probably not work out well for him.
So I meant like occlude the aneurysm sort of separately.
So you could treat, so your traditional sort of saccular aneurysm treatment of sort of coiling or it, for example, but once you see the 3D images, it's just a fusiform aneurysm of this whole disease segment. So it's not something you could treat separately from the carotid itself. So any other options in that scenario?
Use a flow diverter potentially.
Yeah, so flow diverting stent would be an option. Challenge with that is the extent of the diseased vessel. If you imagine, it's also, we're looking at one view here, but if we go back, so I haven't got the lateral, but it's quite a convoluted course with it. And also because the artery is still diseased here, it's quite a size mismatch for the stent from here to here. And also there isn't a stent that's wrong, so you'd have to telescope lots of stents inside each other, which all makes it more complex and increases the risk. And as I was saying, if you lose that vessel, then he'll effectively have a life-ending stroke.
I have a question, Mr. Holsgrove.
Yeah, go ahead.
Is there a room to try a carotid occlusion here?
No, so
occlusion test.
So if you occlude this, so if you occlude this carotid, it will treat this aneurysm, but his left hemisphere and a significant proportion of his right hemisphere are receiving their blood supply through this artery because the right ICA is occluded. So you can't, if you occlude this, he'll have bilateral life-ending strokes.
And is there then room to try a high flow bypass from the external carotid to the MCA?
Yeah. So that would be another option for him. So they would commonly be options for what to do with an aneurysm in this sort of location. We could just watch him, but we've already seen it grown, and that's just in the space of a few years, and he's only 16. This would sometimes be an option, but because he's got an occluded carotid on the other side, it's not really feasible for him. And flow diverting stents, as I mentioned, can be considered, but is more complex with him due to the extent of that disease vessel. And bypass would be another option, but rather than bypass the occluded carotid on the right, we would be aiming to bypass the aneurysm to allow us to treat the aneurysm itself. So this, in terms of those different treatments, this is a different patient, and he's presented with hemorrhage from an extracranial pseudoaneurysm of his carotid. And he has a normal carotid on the other side, and you can see they did a balloon test initially and then have coiled that whole segment of the carotid in addition to the aneurysm, and he's got such good cross flow that he is safe. And they would check that cross flow with the balloon test occlusion first and then proceed to this. This isn't realistically feasible for this patient because his carotid is occluded on the other side. For flow diverting stents, they would normally pass the diseased segment, and sometimes you might put coils or sometimes you might not. But it would, if you don't, then it causes a more gradual thrombosis of the aneurysm. And this is a view of what one looks like. So because they're quite heavily braided, it encourages blood flow through in the direction of the stent. It can, so you can still have blood flow passing through the stent, so branches can maintain, because there's sort of, they drag flow through, they will stay patent, but something blind ending like this would gradually thrombose. But again, it was too complex due to the nature of this particular patient's aneurysm to do that. So he underwent high flow bypass, and what that does, it takes, for him, it took a long saphenous vein graft from his external carotid, and then that comes up through here, and you can see it's attaching down to the just below, just the terminal carotid here. Okay. And you can see that that's the bypass graft, all these little artifacts are little liger clips on the venous branches, and it comes down and is onto the terminal carotid. And this is just so the aneurysm was here, and that's thrombosed, and this is just that other little section there, which is over the years since it's just gradually thrombosed. And that's just a schematic view of how that's done.
Mr. Holsgrove, was the distal segment distal to the aneurysm clipped, or was that vessel cut as in the picture?
Oh, so what we did, we just so we ligated the internal carotid in his neck, okay, and then we did consider clipping it here, and then that would trap that whole segment of internal carotid, but we left it just in case his ophthalmic was reliant on it from the internal supply. So, and it's just, so there was a risk that this could fill the aneurysm in a retrograde manner and cause him to continue, but we felt confident that it would just gradually thrombose, and that's what it did. But that would be another option, is to trap it in that way. So if we look at those, so in terms of indications for bypass, which is what we started with, one option is flow preservation, and that is in the case of complex aneurysms, such as this patient, or occasionally for tumours incorporating sort of the proximal vasculature. So you might do it for a skull-based tumour that requires surgery, but the sort of, it's encasing the carotid, and you can't treat the tumour adequately with the without affecting the carotid, so you might consider a bypass in that scenario. And the other method indication is for augmentation of flow, and that would most commonly be for moyamoya, but occasionally for atherosclerotic disease, but not very often. Usually it would just be medically managed. So in terms of flow preservation or flow replacement, so there are different ways of doing that. So EC-IC bypass, so the example I showed was with a graft interposition. So with a long saphenous vein would be commonly used. Sometimes people would use a radial artery, and that would be from the external or common carotid to wherever you need to do it to. or you can sort of do other ECIC bypasses without the graft interposition, and that could be, say, if you had a fusiform MCA aneurysm, you could do a single or double bypass from branches of the MCA onto an M2 branch, for example, or sometimes the internal maxillary artery would be used in a similar way. You can also do intracranial to intracranial bypasses, and this might be with an interposition where you take an M2 from an aneurysm and suture it to another M2, for example, to occlude a section affected by a complex aneurysm. Or potentially you might do an in situ bypass where you could do it with, say, side-to-side bypass of two M2 branches, for example, if you were occluding the origin of one. In terms of flow augmentation, so again, this is normally for moya-moya, and this can be direct, such as the example we showed, and that's where you take the STA and then you have it here with its fascia, and then you clean a section of it, and you do an end to side anastomosis onto a cortical M4 branch normally. Or you can have indirect bypasses, be it using dura, pericranium, all those things we mentioned earlier, or sometimes a combination of the two. Okay. And you might do that if you were trying to help different vascular territories. So you could sort of do this if you're trying to help the ACA territory, and this for the MCA territory, for example. You can use other areas as well, such as the occipital posterior auricular, but the STA would be the most commonly used artery for this. And that's because it's accessible, but also because moya-moya is the most common indication, and it affects the anterior circulation. Normally by using the STA onto an MCA branch, you're effectively treating the moya-moya disease. So we look at moya-moya disease. So I mentioned earlier it's moya-moya disease versus moya-moya syndrome. So moya-moya disease is bilateral, and it's with no associated risk factors. Both of them are progressive occlusive arteriopathys for the ICA and its proximal branches. Okay, so it's an anterior circulatory disease. Whereas moya-moya syndrome can be unilateral or bilateral and is associated with underlying conditions such as sickle, NF1, a history of radiotherapy, or Down syndrome would be common examples. And in terms of presentation, so it can be with ischemia or hemorrhage. Ischemia is more common in children than hemorrhage, whereas hemorrhage is sort of it's about equal, to be honest, in adults. It can present with headaches, and this is thought potentially to be an effect of the collateral circulation forming the increased external carotid branches expanding and potentially causing headaches related to the increased blood flow. There is an association with Asian ethnicity, and it affects females twice as commonly as males. And in terms of diagnosing it, so a CTA can demonstrate the ICA stenosis in the moya-moya vessels. MR imaging can show reduced flow voids. MRA can show a similar effect in terms of the ICA stenosis. You can see moya-moya vessels, you can see evidence of ischemia in terms of previous strokes, and you can see the ID sign, which is this sort of high signal on flare imaging that you'll see lining the vessel stuff. And again, angiography can sort of help in terms of the diagnosis, and that's where you would see that puff of smoke appearance. In terms of treatment, sorry, there is a grading system which I thought I'd included but haven't, and that's the Suzuki grading system, and that's looking at the extent of the stenosis, the degree of collateralization, to sort of grade that. Commonly, for ischemia, we would commonly start aspirin, but because if someone has presented so the most common presentation we see is with ischemia in the combination of adults and children, and because it's a progressive disease, normally when you see ischemia and diagnose moya-moya, you would normally offer treatment in the form of some form of revascularization surgery. In adults, it tends to be more common to do the direct bypass, whereas in children, because their vessels are potentially smaller, and also there has been some evidence that complication rates are higher in children with direct rather than indirect bypass. That's where in children, more commonly, we would look, particularly the younger children, we would look towards the indirect treatments being used more commonly. That's a run through of Moya and bypass surgery. Any questions that anyone has on any of that? I think that's some chat. Okay. Any questions?
Is it more common or does it more commonly affect the MCA territory? It seems to be in a lot of scans that we see.
So it's I mean, it's a disease of the internal carotid and its proximal branches. Because the MCA is a larger branch from it, you would commonly see that affected. But it can, so often you'll see sort of ICA, proximal MCA, but it depends. So you could have, for example, in Moya syndrome, one carotid affected, and if they've got a reasonable ACOM, then the ACA territory could be spared by a cross flow from the other side. So it depends on the exact pattern and presentation, but it can affect the ACA territory as much as the MCA. But it's just because the MCA is a larger territory and a larger vessel, you will often see that sort of stand out slightly more.
Just one quick question, thank you. A sort of young adult with Moya who presents with hemorrhage for the first time, would you always offer surgery at that point, or is there any value in trialing medical therapy for a period?
So the difficulty is the medical therapy isn't really, again, it's not particularly evidence-based. Aspirin is really, so you can look at aspirin, hypertension control, in terms of reducing future risk, but because they've already presented through that, and because it's recognized to be a progressive condition, and even giving those treatments won't necessarily reduce the progression. Normally, if it's a deep-seated hemorrhage in the presence of Moya, you would offer it, although so the evidence, there is evidence, it's not, level 1 evidence for bypass in hemorrhage, but most of the time, following those, so it's only in the last few years there've been sort of more sort of series of patients or cohorts demonstrating reduced hemorrhage risk. So normally I would offer it rather than let them recover from the hemorrhage, go through the workup to assess them, and then offer surgery.
Thank you.
But there is the question of, do you treat both sides or not? So they might have bilateral disease, but they presented with hemorrhage on one side, that may be more severely affected. And in that scenario, so I have some patients who we treated one side, and we're just keeping a watch on them. We'll see the extent to which it progresses. But again, there's no fixed rule on what you must or mustn't do. The other factor is, if you, in any of this, if you're trying to bypass a patient that doesn't need a bypass, it generally won't work, because your bypass won't outcompete nature's own vessels if they're healthy, and so that's more of an issue. So if someone had Moya syndrome, it's very severe on one side, and they had a hemorrhage, and you bypassed it, and hopefully that would reduce their hemorrhage risk. If you bypassed the other hemisphere and didn't really need it, there's a high chance your bypass won't sort of stay patent. And then if the disease does progress in future, then you've potentially wiped out a treatment option by using the most commonly and best placed vessel to help. So I think you do have to consider your moment of intervention in cases where it's not for ischemia.
Thank you very much.
Thanks, Mr. Holsgrove. That was great. Just a question about the aspirin. How do you manage it in the perioperative period in terms of stopping before and restarting after?
Yeah, so that's one of the risk factors with bypass surgery is hemorrhage risk perioperatively. So normally I would have my patients preoperatively on aspirin 75 milligrams, and they would stay on that sort of preoperatively and on the day of surgery and post-op. They would also have, so we normally give them IV heparin sort of intraoperatively, at the point where we are sort of clamping and dividing the STA and clamping the M4 for the anastomosis itself. And we normally flush everything with Hepcel. So, but because of that IV heparin and the aspirin, there is a perioperative hemorrhage risk. But in terms of the aspirin, they would stay on it.
Thank you.
There is a question of what to do with aspirin. So aspirin tends to be used in sort of it's not used as frequently in Japan, for example, as it is in sort of the Europe and the US. And there is debate as to what to do with it in children, for example. Do you keep them on it forevermore? It's recognised that children present more with ischemia, so often they're started on aspirin. But then, do you keep them on it forever? Bearing in mind that adults will commonly present with hemorrhage, and so there's no definite answer regarding that. It's often just a discussion on an individual basis.
I think Mr. George has got a hand raised.
Yes, great talk, Dan. I enjoyed it, even being a spine surgeon, I have to say. You know, if you have a case like the giant aneurysm which you had shown, where actually a flow diverter is an option, or you could go for an ECIC bypass, is there a cost advantage to using one over the other?
So flow diverters are very expensive, and he would have probably needed about 4 of them to pass that segment, which would be about 40,000 on flow diverters alone. However, because of his right IC, so normally when you do a high flow bypass like that, you would temporarily trap the section of the carotid that you were anastomosing to while you perform the arteriotomy and the bypass. Because both hemispheres were reliant on that carotid, I was anxious about sort of ischemia perioperatively. So I took him to Utrecht, where I did my fellowship, and we did Ilana bypass. And what that does is it uses a laser for the arteriotomy, and you can do it in a way that means you don't have to clamp and trap the section of the carotid you're doing your anastomosis to. So for him, it involved a flight and a stay for a few weeks in Holland. So probably no cost advantage either way for him.
But assuming you didn't have to take him, fly him, presumably the surgery would work out cheaper.
Yes, I imagine it would. Yeah.
Yeah.
Although it's a big operation. It's used rarely now. So flow diverters have effectively wiped out most indications for high flow bypasses. So they're the numbers of high flow bypasses, even so in Utrecht, they're a sort of tertiary centre for bypass for the whole of Holland, Belgium and Luxembourg, and their numbers have just declined more and more over the last few years, just as flow diverters sort of take that patient group. So it's rarely indicated now, and it's a big operation, and it's not, there are significant risks to it. So I think there is a place for flow diverters, certainly well established now.
All right, thank you.
Any other questions? Helen's joined for the questions at the end. Anyone else? Okay, should we leave it there then, Sean?
Yep. Thanks a lot.
All right. Thank you, everybody.
Thank you.
Thanks everyone for joining. Please complete the feedback. Thank you.
Thanks, Mr. Hallsgrove.
You're welcome.